Hello. So the case I'll be presenting today is about a patient who presented with headache. He was a 79-year-old Caucasian male with a significant past medical history of a left frontal hemorrhagic stroke. He presented to the ER with his wife after a ground-level fall. Per the patient, 2 days ago, he experienced a fall while out playing poker with some friends. The friends reported to his wife that he fell and landed on his shoulder, but they did not believe he hit his head at the time. He did sustain a small abrasion to his right elbow as a result of the fall. The patient reports yesterday he experienced multiple vomiting spells as well as difficulty walking, thinking I was just hungover, stating, "I did not think anything much of it at the time." This morning his wife woke up and noticed blood on the bed pillow as well as a bleeding abrasion to the back of his head. She believes that he fell sometime during the night last night while going to the bathroom. However, the patient has no recollection of this happening. This compelled her to bring him to the emergency room for further evaluation. The patient states his headache began when he woke up this morning. He describes it as throbbing and dull. It is localized to the right occipital lobe. The pain is constant and rated 7 out of 10. He states nothing has made the pain worse so far. He did present with an ice pack to the right occipital lobe, which he endorses does alleviate some of his pain. He denied taking any over-the-counter or prescription medications to relieve the pain. He denies associated symptoms of fever, chills, or malaise, but he does endorse occasional dizziness in the past few days. He was noted to have a 4.5 centimeter laceration to the right occipital lobe. As far as his history, he had a hemorrhagic stroke without paresis, hypertension, hyperlipidemia, and type 2 diabetes. He has had an appendectomy in 2014 that required a 2-night stay. Other than that, he's never been hospitalized. He's up to date on all of his vaccines. He gets his preventative exams yearly with his primary care physician. He denied any food, medication, or environmental allergies. His current medications are amlodipine, pravastatin, metformin, glipizide, lisinopril, acetaminophen, and carvedilol. Family history was pertinent for his father also having type 2 diabetes, hypertension, and hyperlipidemia, as well as his mother having hypertension, hyperlipidemia, and carotid stenosis. As far as his social history, he lives at home with his wife. He endorses daily alcohol use of 3 to 4 drinks of whiskey per day. He does deny tobacco or illicit drug use. He is a retired construction worker who completed his high school education. He eats primarily low-fat diets consisting of lean meats to control his hypertension and diabetes and hyperlipidemia. He does not regularly exercise. He has not traveled outside of the U.S. recently, and he is independent with his ADLs at home. Review of systems was negative for most things, positive only for these following pertinent things. In his head, ears, eyes, nose, throat, he endorses right occipital head pain related to his fall. He denied vision changes and hearing loss. He also endorsed occasional dizziness and denies any known syncope, but he has had the falls. He denied any other symptoms such as shortness of breath, chest pain, abdominal pain, muscle weakness. He did endorse recent gait disturbances. His physical exam, his vital signs were temperature of 98.6, blood pressure 106/60, heart rate of 76. He was setting 97% on room air, respirations were 17, pain was 7 out of 10. He is 5'9" and weighs 79.8 kilos with a BMI of 33. He was elderly and well-groomed. He appeared uncomfortable but made eye contact and answered questions appropriately. Head, ears, eyes, nose, throat. A 4 centimeter laceration was noted to the right occipital scalp. Head was otherwise normocephalic. Ears were patent with pink turbinates. Oral mucosa was moist and intact. Trachea was midline. Neurological exam revealed expressive aphasia when identifying his current location. He was, however, able to state his name and date of birth appropriately. Pupils were +2 and reactive and equal to light and accommodation. Extraocular movements were intact. Cranial nerves 1 through 12 were intact, and he did not have any hemiparesis. Respiratory lungs were cleared, auscultation bilaterally, no pertinent findings, no subcutaneous air, respirations equal and unlabored. Cardiovascular assessment revealed S1, S2, no adventitious heart sounds were noted, no JVD or edema. There was a slight bruit noted over his right carotid artery. Abdominal exam was benign. Soft and non-tender, non-distended, bowel sounds were active, no rebound tenderness. Musculoskeletal, his range of motion was active in all extremities, and his Romberg test did end up being positive. For diagnostics, we performed a CT scan without contrast of the head and with contrast. This revealed a crescent-shaped, homogeneously hyperdense extraaxial collection, which spanned the right hemisphere. We also obtained a bilateral carotid Doppler ultrasound. So we got the carotid ultrasound to evaluate for any carotid stenosis. Given the bruit that we heard, we felt that this was appropriate. The carotid ultrasound did reveal 50% stenosis in the right carotid artery, 10% carotid stenosis in the left carotid artery. We also got an EKG, which was essentially benign. He was a normal sinus rhythm, heart rate of 72, no ST elevations, and we got this because it is indicated when patients present with an unexplained syncope and dizziness. We also got a CBC and BMP. We were concerned for bleeding in the head, so we knew that the patient could accumulate a significant amount of blood in the subdural space and display anemia, which he in fact did. His hemoglobin was 8.2, hematocrit was 31.2, white blood cell count was 11.2, and platelets were 298. We also got a BMP. It was informative with attention to the serum potassium because hyperkalemia heralds the breakdown of red blood cells that could have extravasated into the subdural space. He did not show any hyperkalemia. Potassium was 4. All of his other electrolytes were within normal limits. He did not show any renal failure. Blood sugar was 197. Our primary diagnosis was a subdural hematoma. This was based on the statement that he has had 2 recent falls, one that resulted in amnesia and a laceration to the head. This raised our suspicions to a head trauma. This, coupled with his vomiting, difficulty walking, and syncope, raised suspicion for compression on his cerebral structures. Differentials included hydrocephalus and subarachnoid hemorrhage. Secondary diagnosis was stroke, given his prior history of a hemorrhagic CVA with his current neurosymptoms. He wasn't showing the classic hemiparesis, left or right-sided. However, he did have expressive aphasia, gait disturbances, and repeated falls and memory loss. Differentials for a stroke could be seizure and hypoglycemia. Third diagnosis was carotid stenosis, given the exam finding of the bruit as well as a 50% carotid artery stenosis on the right, demonstrated he was indeed suffering from carotid stenosis, which could be contributing to his current symptoms. Differentials included aortic stenosis and stroke. So our recommended medications for this patient included a 3% hypertonic saline infusion to decrease ICP and increase cerebral perfusion pressure. We also recommended Fioricet 50 milligrams, 300 milligrams, 40 milligrams, and to take 1 to 2 tabs as needed for headache pain related to his subdural hematoma. We chose Fioricet because this patient population has a contraindication for vasoconstrictors, which could increase ICP and worsen neurosymptoms. We also recommended atorvastatin. He takes this 20 milligrams a day to inhibit cholesterol synthesis, and this will prevent worsening of his 50% right ICA stenosis. We also consulted neurosurgery to evaluate the subdural hematoma that was seen on his CT scan, admitted him to the trauma ICU for medical management and monitoring, and consulted cardiology given his hypertension and hyperlipidemia. We also consulted vascular surgery for his carotid artery stenosis. Thank you.